In this video, we will talk a little review about the uh, inherited coagulation disorders. The inherited coagulation disorders comprises of the three diseases, which are the hemophilia A, hemophilia B, and VWD, or the von Willebrand disease, which we are going to talk about in the next picture. So, inherited coagulation disorders. These are the coagulation problem which are inherited from the parents to the offsprings, and they have got a thing to do with the coagulation. We know that in primary hemostasis, platelets come together, they make a clump which we call the primary hemostasis with the help of the von Willebrand factor on them. In the secondary hemostasis, the clotting factors, they join together to ultimately make the thrombin, or the activated thrombin are factor 2 and fibrin strands in between the clot platelets. So this whole process is known as the process of coagulation. Now, if we specifically talk about the hemophilia A and B, they are because of the clotting factor deficiencies. Hemophilia A is because of the factor 8 deficiency. It is synthesized in the liver under the effect of a gene which we call the XQ28. It's located on the X chromosomes. So the females are the carriers, and 50% are of their sons, they develop the hemophilia A. 50% of their daughters, they are the carriers, and the 50% of the son are the normal. But in case of the males, all of their daughters are carrier, and their sons are the normal. So it is transmitted from the mother sides, they are the carrier. Whenever there is a mutation, there is deletion, there is inversion, or a very famous inversion of the intron 22, or it can be also the insertion, causes 50% of the time the hemophilia A. Now, normal level of the factor 8, which is a clotting factor, and it is utilized in the secondary hemostasis during the extrinsic and intrinsic pathway. The normal value is 50 to 150 international unit per deciliter, and hemophilia A is subclassified based upon the concentration of the factor A in the body. In the most severe form, it is less than one unit, 1 international unit per deciliter. In the moderate category, it is between 1 and 5 international unit per deciliter, and in the milder form, it is more than 5 to 10 international unit per deciliter. So this has got a very much impact. The subclassification has got a very much impact on the clinical feature of the patient, because in those patients who have got the most severe deficiency and most severe problem, they spontaneously bleed into the joints and the muscles. They can have spontaneous epistaxis, they can have spontaneous bleed from their teeth, may have intracranial hemorrhages, and they may have the menorrhagias. But in case of the moderate category, they need to have an injury, or they, after the surgery, they have delayed stopping of the blood. But in case of the mild form, when the clotting factor 8 level is more than 5 to 10 international unit per deciliter, then what we see that these patients go to the adolescence before they are diagnosed as a case of hemophilia A. The prevalence of the hemophilia is 1 into 5,000 male, as compared to the hemophilia B, which is 1 into 30,000. So when we do the labs in these patients of the hemophilia, their PT is normal, prothrombin time, their bleeding time is normal, they have got a normal von Willebrand factor, they have got a higher or prolonged activated partial thromboplastin time, and they have got low factor 8 deficiency, which makes sense because that is what defines hemophilia A. What are the treatment options we have got in patients of the hemophilia A? We can give factor 8 concentrate, which is either naturally derived from the plasma, which has got a half-life of 12 hours, or it can be bioengineered, or the recombinant form of the factor 8 concentrate, which is though higher in prices, but it has got a higher duration of action, 1.5 times more than the natural one. Second option, if we can use the desmopressin, which is a vasopressin analog, and it not only increases the concentration or synthesis of the factor 8, it also increases the concentration or synthesis of the von Willebrand factor from the endothelium. So desmopressin can be available in the intranasal form, subcutaneous form, and IV form. All those patients who developed antibodies against the factor 8, and they are the one who have severe form of the hemophilia A, in those we can bypass the factor 8 and its associated antibodies by the use of activated factor 7 concentrate and activated thrombin complex concentrate. This is how we can bypass the antibodies, which are very much a problem nowadays. And on the longer term, we can give immunosuppression to suppress the action of the antibodies formed in these patients. Now in case of the hemophilia A, we can go for the carrier detection, because these females, as a result of lionization in the early age, embryonic age, one of their chromosome is sort of silent and one is working, so we can detect the carriers by using the molecular and genetic studies. And antenatal detection is also possible by using the DNA analysis or the mutation analysis in case if we want to terminate the pregnancy by knowing the status of the fetus. We should do it during the 11 to 12 weeks of pregnancy by the chorionic villus sampling. But if we are not intended to terminate the pregnancy, then we can wait up till the third trimester to do the amniocentesis and molecular and genetic studies on these. So this sums up the hemophilia A. Hemophilia B is also known as the Christmas disease, not because of the Christmas or Easter event, but because of the person who was first diagnosed with this problem. It's also known as the disease of the Russian royal family. In this disease, there is a decreased factor 9. Factor 9 is deficient. It behaves more like a hemophilia A, where it is a X-linked disease, and clinical feature and the lab investigation are the same, and but the treatment differs in respect of that. We give the factor 9 concentrate rather than the factor 8, because that makes sense, it's deficient in the factor 9. And we also go for the gene therapy, but there is no use of desmopressin because it doesn't address the factor 9. Now there is a historic perspective to the hemophilias, especially the hemophilia B. During the last decades of the 19th century, Queen Victoria was suffering from this problem. She was a carrier of the hemophilia B, and five of her daughters, only two were the carriers, Princess Alice and Beatrice. They were married to the Spanish and Russian and to the German royal families, and there the sons developed the hemophilia. So it has got a historic perspective when we talk about the hemophilia, which are two of the three very important inherited coagulation disorders. So the third disease in the inherited coagulation disorder is the von Willebrand disease. VON, von Willebrand, WILLEBRAND disease. It's a autosomal disorder. It's an inherited disorder, but it's the autosomal one. The difference between the X-linked and the autosomal recessive autosomal disorder is that we are made of 46 chromosomes. 22 pairs are non-sex chromosomes, also called the autosomal chromosome, and one pair of the sex chromosome X and Y in the male and XX in the female. So as opposed to the X-linked diseases, which are transmitted through the X chromosome, these autosomal, they are transmitted through the non-sex or autosomal chromosome. For example, von Willebrand disease is transmitted because of the defect or mutation on the chromosome 12, where located gene, where we see the location of a gene which encodes for the von Willebrand factor formation in the endothelium. So because of the mutation or defect over there is a decreased or impaired formation of the von Willebrand factor. What is the role of the von Willebrand factor? Here we see in the blood vessels that these platelets, these have got glycoprotein receptors through which these von Willebrand factor, it clumps the platelets together when they are to be attached to these some endothelium because of the injury or bleeding issues. So it not only does this process, it also protects the factor VIII from destruction by other components. So it has got two major roles to play. Now, this von Willebrand disease can be subdivided into type 1, 2, and 3 based on the inheritance and also the problem. For example, in case of the type 1, there is an partial lack or partial decrease in the quantity of the von Willebrand factor, and this is a autosomal dominant inheritance. What is the difference between the autosomal dominant and autosomal recessive? For a disease which is autosomal dominant, only one of the gene, either from the father or the mother, needs to be defected for the disease to be transmitted down to the offsprings. But in case of the autosomal recessive, both the genes from both the parents should be defected before it shows up in the offsprings. So type 1 impaired quantity, decreased quantity, and autosomal dominant inheritance. In type 2 impaired quality, but the quantity is not affected. Again, this is autosomal dominant. And the most dangerous one is the type 3, which is the complete absence of the virus, and it is a autosomal recessive. Clinical feature almost same as that were for the hemophilias, like they especially in case of the type 3, they can spontaneously bleed into the joint and the muscles. They can develop intracranial hemorrhages. They can have epistaxis, menorrhagia. They may have post-op non-stopping of the blood. They may have bleeding because of the trivial injuries. So what are the lab values? They are a little bit different than the hemophilias in case of the von Willebrand factor, and it makes sense. Not only the von Willebrand factor is low, also the factor VIII, because factor VIII is easily destroyed once there is a lack of the von Willebrand factor. So both of these are low, but bleeding time and activated partial thromboplastin time, they are very high, but PT is normal. So other than the prothrombin time, every other factor is disturbed. So what is the treatment? Treatment largely focus on the factor VIII concentrate, because this factor VIII concentrate not only contains the factor VIII but also the von Willebrand factor, which is mainstay of the treatment nowadays. So it is given twice a week or thrice a week, or before the surgery, or if there is going to be a bleed. Other than this, we can also use the desmopressin, which is a vasopressin analog and is available in IV, intramuscular, and intranasal. And we have seen that it not only increases the factor VIII concentration, but also it increases the synthesis of the von Willebrand factor by the endothelium. So other than this, nowadays von Willebrand factor concentration itself is under process. It's in the clinical trial. It may be available in the near future. We can also use the cryoprecipitate, but there is a problem with it because these are not virus inactivated, so there are higher chances of the transmission of the hepatitis C virus and HIV virus. Though this risk of the transmission of the infection remains even with the plasma concentrate. So that's all about the inherited coagulation disorder. And if you like the video, please do subscribe the channel, press the bell icon, and ask other friends to like the channel and subscribe the channel, especially if they are the doctor, because it can be of some help to them.